And it gives me really a great pleasure to invite a colleague and a friend, Prof. Omar Alobaid, who is going to talk about the management of diverticulitis and the updates. Prof. Omar, the podium is yours.
بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على أشرف الأنبياء والمرسلين. At the beginning I would like to thank the organizing committee for giving me the pleasure to be here with my colleagues. So my talk today will be about the modern management of diverticulitis. This is a question used to be a very easy question more than 20 years ago, and when would you operate on a patient post an acute complicated attack of diverticulitis with pelvic or retroperitoneal abscess? If we look at this slide, we will notice that before 2002 we were very generous in operating on patients with all types of attacks of diverticulitis, whether it's uncomplicated or complicated diverticulitis, emergency and or elective surgery. If you look at the rate of complicated diverticulitis, which is the one with red at the top, we'll see more than 50% drop recently in the rate of surgery. My colleagues who were there before the year of 2000, the message was very clear and the answer was very easy. We were depending on age. If the patient more than 50 years of he's more than 50 years old, then you operate after the second attack, regardless whether it's complicated or non-complicated. If the patient below the age of 40, then you do an elective surgery after the first attack for uncomplicated diverticulitis, and same admission for the complicated diverticulitis. Life at that time was much easier than now. However, a lot of people started challenging this concept, and they have come up with a different criteria than the easy criteria on the 20th century. This is just to show you that the pathophysiology of diverticulitis is more complicated than what we used to think at that time. It includes multiple variable factors, including the host factors, the immune response, and the bacterial or microbe factor. Now, one of the good studies that looked at the factors that will affect or will cause an increased risk of recurrence of attacks of diverticulitis was this study, and retroperitoneal abscess was the variable that has a great effect on the recurrence of diverticulitis. If you develop a retroperitoneal abscess, then your hazard ratio is more than 4.5. Other factors including family history, and if the involved segment is more than 5 centimeters, and right colonic disease as compared to the left side. Now, after an acute diverticulitis, we have to assess the patient, especially if it's uncomplicated. And we used at that time to use barium enema, ultrasound, till the late 1990s, where the CT scan became the standard or the gold standard test to assess patients with diverticulitis. Now, part of the assessment is also to do or not to do an endoscopy for those patients. I think most of those patients, they are above 40, so by definition, those patients should, if they have not had an endoscopy in the past, they should go for at least a screening colonoscopy or at least a flexible sigmoidoscopy. Now, what are the criteria that will make us 100% sure to do a colonoscopy? I think if it's a complicated diverticulitis, because the risk of cancer in complicated diverticulitis based on some of the series is up to 11%. If the attack is uncomplicated, then the risk go way below 1%. So if we have a complicated diverticulitis, if we have a segment more than 5 centimeters and old age, so we should do a colonoscopy. Now, the timing is the colonoscopy is very important. Most of us will do the colonoscopy 6 weeks after the attacks. However, there have been a lot of studies that showed doing the colonoscopy on the first admission or during the acute attack in an expert hands could be safe to do. Now, after assessment, we come to the treatment. For the treatment of, I'm here talking about uncomplicated diverticulitis. Basically, we treat them all with antibiotics, but is this necessary or is this right? We'll see through a couple of randomized controlled trials. One of the first trials is the Alobaid trial, and it is a Swedish trial where they have randomized 623 patients into admission and IV antibiotics. They use the amoxicillin and or clavulanic acid. They have given the patient 2 days of IV antibiotics, then they switch them into oral antibiotics versus just IV fluid and bowel rest with pain medications. This study came out with no difference in pain, fever, progression to complicated disease, and length of stay or recurrence rate at 1 year. No difference between the IV antibiotic group or the antibiotics group and the IV fluids group. The second trial, which was a Dutch trial, the Alobaid trial, 500 to 80 patients, they came up with the same conclusion. But this trial, they have even followed up, they have a second results, long-term follow-up of those patients. And again, there were no difference in all measures, especially recurrence of the disease with the IV antibiotics group or the oral group. But this trial is interesting. They have 13% of the patient. They were treated as an outpatient at home. They did not require admission, whether they give them oral antibiotics or no antibiotics. After the treatment, then we come to the surgical option. Now, we come back to the first option. Do we have to operate on every patient with diverticulitis? The answer for the uncomplicated diverticulitis, there are some criteria. We rarely now operate on patients with uncomplicated diverticulitis. However, there are general principles for treatment of diverticulitis. We don't need to remove the whole bowel with the diverticuli. No, we have to remove only the thickened bowel where there is hypertrophy of the muscles, and this is we make the judgment intra-op. For the distal end, we need to go all the way down to the peritoneal reflection, diversion of the recti, and by doing this, you will eliminate or reduce the risk of recurrence of diverticulitis down to less than 4%. For the IMA, do we have to do a high ligation versus no or low ligation? I think even for cancer now, we have good evidence that high ligation probably is not needed. The question is, do you ligate the superior hemorrhoidal artery or you go all the way to the trunk of the IMA? I mean, if you go all the way to the trunk of the IMA, then you are increasing your risk of complication, especially the leak, because you are devascularizing most of the left colon. However, the judgment, which I have noticed from my practice, especially here in Saudi Arabia, is based on the connectivity of the bowel. Most of the time, if you don't go to the trunk of the IMA, it will be very difficult to bring the left colon down to the peritoneal reflection and do the anastomosis. So the judgment here is based on the tension, not based on the ligation of the blood vessel, whether it's high or low. So what to do after an episode of uncomplicated diverticulitis. We know that most of the emergency colectomies performed with the first episode. So our fear or worry about future emergency surgery will be down to 1 in 2,000. So I think this should not be part of the judgment. The practice of recommending routine elective colectomy should be avoided. And this is from the ASCR practice parameters 2014, and it was reinforced in 2021. The director trial looked at the surgery versus watch and wait, but here for diverticulitis, not for rectal cancer. They ended by a recommendation of doing surgery after 3 attacks of uncomplicated diverticulitis or from the first attack with persistent symptoms. 23% of non-operative group went to require colectomy after the study period. However, they came up with the decision will be based on the judgment on the disease frequency, whether you have more attacks on the first 6 months versus more attacks on the following years, disability and number of hospitalization, number of days patient being away from work, and of course, we don't forget the age and the comorbidity of the patients. After complicated diverticulitis, this is the question. What we mean by complicated diverticulitis, Hinchey 2 or 3 or 4. Hinchey 3 and 4, most of the time they will require emergency surgery. The problem is with Hinchey 3, abscess, fistula, bowel obstruction, or the presence of extralaminar air.
Omar, conclusion?
Sure. So basically to just those patients, if you have erythroperitoneal or pelvic abscess, they require surgery, even after drainage. Now, if you have a fistula, bowel obstruction, or extralaminar air, we'll keep the extralaminar air at the end, but for the first 2, yes, they will require surgery. Now, if you have extralaminar air, we're talking about probably Hinchey 3, Hinchey 4. I'm not talking about localized air bubbles, no generalized air. So with Hinchey 3 and Hinchey 4, you have to go in. The question, do you do a lavage or just a resection? Multiple trials, some of them they were aborted, and at the best, data that's supporting lavage is equivocal, and probably if you do it, be ready to intervene in the near future or in the first year. I'll just come to the conclusion from, again, the ASCR practice parameters 2014, which were reinforced in 2014. Following a successful medical treatment of mesocolic abscess more than 5 centimeters, be prepared to do for these patients an elective emergency sigmoid resection. Now, when you do if you do an emergency, the last point, if you do an emergency resection, what is the best thing? Is to do a Hartmann or to do an anastomosis with a lobaliostomy based on the randomized control trial done in Switzerland for 4 centers. Doing a primary anastomosis with a lobaliostomy is better, especially if we look at the mortality was 0 from this compared with the Hartmann, and 90% of the lobaliostomy were closed, as opposed to only 50% of the Hartmann that was closed. Thank you so much.